Parotid cancers can be very scary. What steps do you need to take to treat it appropriately? I'm Dr. Babak Larian from Center for Advanced Parotid and Facial Nerve Surgery, and we're going to discuss that today. There are many different types of cancers and tumors that can happen in the parotid gland, but let's discuss the gland and its function first. This is the parotid gland. This is the submandibular gland. These are the sublingual glands. And what they do all day is produce saliva that through the ducts get transferred into the mouth. And what the saliva does, it's wash away some of the bacteria in the mouth, lubricate the food, and prepare it for swallowing and digestion. So they perform a massive function. And they usually make about 2 liters of saliva. So one of those big soda bottles is how much saliva you make on a daily basis. You have to hydrate well to maintain that flow. There are many different types of cells in the salivary glands, so that's why you can have many different types of tumors. There are also stem cells and progenitor cells that are precursors to these different types of cells, and those can turn into different types of cancers. Parotid gland is the gland that most often will develop tumors in it. 80% of the tumors of the salivary glands happen in the parotid. Fortunately, the parotid has the least frequency of cancers in it. Right? So most of the tumors in the parotid gland, 80% are benign and only 20% are cancerous. Submandibular gland, that's 50-50. So the smaller the gland, the more likely that it can be a cancerous tumor that grows in them. There are 15 different types of benign tumors. Pleomorphic being the most common type at 72%, and pleomorphic adenoma is interesting in and of itself, which we'll discuss. And 20 different kind of cancers that can happen in the parotid gland. Mucoepidermoid being most common, followed by adenoid cystic. Now, pleomorphic adenoma, just like we discussed, is a very interesting tumor because it can, even though it's benign, it can transform and become a cancer. So it can change into this, and under the microscope, this is what a cancer looks like, and this is what a benign pleomorphic adenoma looks like. Right? This just looks like an angry version of it. The chance of this transformation happening is 10% at 15 years. So if you have a benign tumor that is a pleomorphic adenoma, you should definitely address it, because if you give it enough time, it can potentially transform into a very aggressive cancer that can spread and go to other parts of the body and can be hard to treat. Pleomorphic adenoma and cancers can have little legs on their surface. You can see these legs coming out of them. When these legs come out in the cancers, they can grow like roots and kind of fixate the tumor to the surrounding tissue and invade and eat through the surrounding tissue. And so that's why when we examine the patient, we try to see if the tumor moves or not. Because if the tumor moves, that means it hasn't laid out deep roots yet. And that can be obviously very, very positive. During surgery, those roots matter, because if the surgeon gets too close to the tumor and amputates any of those roots, well, in time, those little roots can grow and become a recurrent tumor. So one of the reasons the tumor can come back is if you amputate the little legs that it has spread into the tissue. That's why we usually try to get an additional amount of tumor, of the normal healthy tissue around a cancer, so we can avoid those little legs. Now, the cancers can be small, or tumors can be small, bigger, and much bigger. Now, these are all benign tumors. These are not pictures of cancers, but cancers can grow to be this size or even bigger if given enough time. The best way to figure out what you're dealing with is to do a needle biopsy, right? By doing a needle biopsy, then you can see what kind of tumor you're dealing with. Is it benign? Is it cancerous? If it is benign, is it a pleomorphic adenoma that can potentially become cancers in the future? Or no, it's not pleomorphic adenoma. It's another type of benign tumor that never will become a cancer. So the decision to take it out is based on how fast is it growing, or is it growing at all? Right? Is it bothering you in any way, putting pressure on your face, giving you discomfort and so on, right? Rather than the potential. Now, the other important thing is if it's a cancer, to see what type of cancer. So going back here, if you recall, there are 20 different types of cancers. Some are slow-growing, low-grade cancers. So actinic cell carcinoma, for example, is a very slow-growing cancer. It happens in about 4% of tumor. There's mucoepidermoid carcinoma. Mucoepidermoid carcinoma can be low-grade, which like actinic cell can be very slow-growing, or high-grade, which can be very aggressive. So knowing the different types of tumor you're dealing with can allow you to decide what you need to do. Adenoid cystic carcinoma is a very interesting tumor. It is slow growing, but it likes the nerves and uses the nerves as highways to travel in all directions. So when you have an adenoid cystic carcinoma, your concern for nerve involvement is much more. And you have to decide in advance of surgery, what are you going to do with the nerves if they are involved? So that relationship between the doctor and the patient is very much important in this scenario, because you have to plan what you're going to do during surgery based on what you have. Also, some of these tumors or cancers like spreading to the lymph node and some don't. So knowing that will help you decide what incision you need. Does it need to go down in the neck to address the lymph nodes or not? When you have a mass, when you see an ENT specialist, ear, nose, and throat specialist, or a neck cancer specialist, you need to do a biopsy. That's really important. So see a specialist that treats parotid tumors on a regular basis. They should be doing more than 50 parotid tumor surgeries a year to have expertise, right? And then once they see you, they'll do a needle biopsy to see what kind of tumor you have, hopefully benign, but if it is cancerous, knowing what type, so they can decide the extent of surgery, what needs to be done about the facial nerve, and so on. Some of the ominous signs of having a tumor that's cancerous is having pain, chronic pain in that area, having weakness of some of the muscles of your face, which means the tumor is eroding or invading into the nerve of the face, the facial nerve. Having lumps in the neck, if you have multiple lumps that are growing, having a tumor that's not moving, those are bad signs for a parotid tumor. So your doctor really needs to kind of figure all of these out and plan a treatment plan for you. Surgery, most parotid tumors require surgery. Lymphomas, they don't, but all the other types of tumors and cancers, the primary treatment is surgery. And then your surgeon, after surgery, can tell you what other types of treatments. Do we need radiation? Do we need chemotherapy or immunotherapy? All of these things are considerations that can be figured out after the surgery is done and we see how involved the tumor is and what type of tumor you have, what's the genetics of the tumor, and how we can address it. Now, the likelihood that the cancer will come back is based on multiple things. First, the genetics, what type of tumor you have and how aggressive are the genetics of the tumor. And also, how widespread are the legs? Are you able to get the whole thing out? Or some of the pieces are left behind during surgery because they were around vital structures, the blood vessels going to your brain, and other nerve structures, and so on and so forth. And these are some of the important factors that you and your doctor need to discuss before surgery and what to do when you face that. Facial nerve itself is really important as well. Now, your doctor is probably going to do an imaging study. MRIs are by far the best imaging study to look at the location of the tumor. You can see here, you can delineate the tumor very well on an MRI. This is the parotid gland on the affected side. This is the parotid gland on the non-affected side. This is your jawbone here, and obviously the teeth. So the extent of tumor can be clearly seen by an MRI. MRI is by far the most accurate scan to look at the extent of the tumor and what it's involved, what it's next to. The facial nerve can have varying shapes and forms. So it's like a tree. Every tree is different. So the nerve branching system can be very different. The relationship of the tumor to the nerve can be very different. Some tumors are superficial, as you see here. Some can be deep to the nerve. This is the branching system of the nerve that's superficial to that particular tumor. And some tumors can wrap around the nerve. The nerve comes in here and then exits with multiple branches. And all of that matters. Unfortunately, you can't see the nerve on any scan. So the MRI doesn't show the nerve inside the parotid. CT scan can show the nerve inside the bone of your skull, but not when it enters the gland. So the scans can't tell you what the relationship is. They can give you an indication of how big the tumor is and potentially how involved they can be. When a recurrence happens, usually there's multiple pieces that are left behind and come back. And so the surgery for a recurrent tumor can be more extensive. Having an expert team during your parotid cancer surgery is really, really crucial. So having a parotid cancer surgeon to remove the gland, try their best to save as many branches or all of the branches of the facial nerve preferably. And having a facial nerve reconstructive surgeon present also is really, really crucial, because if you go in there and lo and behold, the tumor is wrapping around the nerve, then, and you can't open up the tumor and save the nerve and pull out the tumor. Sometimes we're able to do that. But if you cannot do that, you need to have a facial nerve reconstructive surgeon to help reconstruct, potentially reattach the two ends of the nerve, potentially put a separate piece of nerve in between that cut portion if those nerves can't be brought together, or doing other reconstructive techniques to help get the nerve back in its best shape possible, or do reconstructive measures so you prevent droopiness and drooling and help the eye closures and all those things that can be done at the same time. And some of these procedures can be done in a sequential manner at later dates. It all depends on the aggressiveness of your tumor and your treatment plan. Sometimes you need to have radiation treatment first before doing reconstruction for the eye. Most of the time, the nerve reconstructions are done exactly at the same time, so you can optimize treatment outcomes. Hopefully this is helpful to you. If you have any questions, please leave us a message or contact us through our website, parotidmd.com. If you like this video, please subscribe. There will be more videos that hopefully can help you along your journey.